Everything seems to be working. I see many names on the WebEx from counties across California, which is great. And I can assure you our slide deck is now complete, so we're ready to go. So let's just go ahead and get started. We'll move through the agenda here. We'll touch on super high level, brief historical perspective, just to give us some level setting and context as to what led up to the IST growth cap. And we'll provide really baseline overview of the program itself, and then dive right into more of the details around the updates, the recent updates to the growth cap program. So moving into the brief historical perspective, let's move into this next slide here. This slide shows that our felony IST referrals have been growing year after year. In 2014, you can see all the way over there on the left-hand side. During that calendar year, we received just under 3,000 referrals for IST treatment. And as of last year, which is calendar year 2022, we received over 5,400 referrals. You can see we denote the little dip in 2020 related to the COVID pandemic. This yellow bar that cuts through all of the blue bars, this represents our IST wait list. During all of the years represented in this chart, we were steadily really increasing our bed capacity across different programs, but despite these efforts, we couldn't keep up with the demand in new referrals coming our way for IST treatment. And as you can see, in 2014 and 2015, the wait list hovered right around 400. Then it increased to the mid 800s between 2017 to 2019. And we experienced a significant impact during the pandemic. And while you can't see it on this chart here, in the spring of last year, 2022, the wait list at DSH increased to a high of over 1,950 individuals. I'm very happy to report that it is much lower now, and in the 700 range or lower. This slide represents our three-prong approach to the substantial growth in those IST referrals. Primarily capacity is the main thing that we were focused on and we have been focused on all across these years. We needed to build more beds. Prior to 2018, we pretty much had our state hospital beds and started funding jail-based competency treatment programs. That started with a pilot back in 2010 and really started gaining momentum and growth, mostly around the 2015-16 timeframe. In 2018-19, we launched our first felony IST community-based restoration program in partnership with Los Angeles County. At the time, that was about 150 beds, and then over the next few years had grown to over 500, and we've just finalized our contract with them to over the next few years, that'll increase to over 1,000 beds. In addition to capacity, we really also focused on our systems. This is really streamlining and creating efficiencies in our processes. Some of our efforts included tightening up our IST treatment programs, resulting in a reduced average length of stay for individuals, so we really could serve greater numbers of individuals across all of our programs. We also established a patient management unit to centralize our referral process. And we're really able to also improve the process through various legislative changes. On the demand side, we've been studying this population for more than a decade, trying to figure out what the drivers of the IST increase have been. And as of 2018-19, we launched our pilot DSH diversion program for felony IST individuals. And we hoped at that time, the way that the program operated, and in some case still continues to operate in the pilot counties, we also, in addition to IST individuals, we had authorized and allowed the diversion of individuals who were likely to be found IST in hopes we could divert them ultimately from that IST commitment. Like many other states, California, we are facing a ton of legal pressures around IST wait times. The American Civil Liberties Union hit us with a lawsuit in 2015, which we call Stiavetti, the Stiavetti lawsuit. And in the years preceding this case, we had other courts ordering specific timelines for admissions to an IST treatment program. The case referenced here, Loveton, was a case out of the same court that issued the Stiavetti order requiring us to admit IST patients within 60 days of commitment to DSH. This was the standard that we were working toward at that time. And unfortunately, after appealing the Stiavetti order, the court finally ruled in favor of the ACLU, which requires us to commence substantive competency treatment within 28 days of that IST commitment. And as you can see here, we must hit that mark by February 27th of next year. From a policy perspective, we have been focusing our efforts over the last few years on increasing the availability of community treatment for individuals, IST individuals committed to the Department of State hospitals. We wholeheartedly believe that in order to break the cycle of criminalization, our patients need meaningful community-based treatment along with housing and wraparound supports to ultimately reduce the likelihood that a former IST individual is going to cycle back through the criminal justice system. And so this is really the depiction of that cycle. This is a list of prior year investments made to increase bed capacity and programs to serve more IST individuals. Other than our jail-based competency treatment program, the majority of the investments that you see here are focused on community-based treatment. The first 4 programs that you see on this list are specific to incompetent to stand trial individuals, and the 2 other programs represented here are supporting our conditional release program, otherwise known as CONREP, which serve both incompetent to stand trial individuals, but also provide an expanded community treatment options and opportunities for NGI and OMD patients who are in our state hospitals, but may be ready to step down into the community. And through that step down, that allows for additional hospital capacity to serve more IST individuals if they need that level of care. This slide just represents 2 former proposals that we had submitted back in fiscal year 2021 and 21-22. These ultimately did not move forward, but just wanted to provide this information to folks to demonstrate the other efforts that we have made to try to increase directly more opportunities to serve IST individuals in the community. These were moved forward as and presented as pilots and demonstration projects to partner with a handful of counties to serve more individuals in the community. Ultimately, these 2 did not move forward, but we did learn a lot of information after releasing these proposals. We did meet with a number of different county organizations and directly with counties and heard firsthand, received their feedback as to what was working, what was not working in the proposal. And all of that information ultimately did inform us moving forward in the additional proposals that we have put forward, namely our IST Solutions budget package, which we'll talk about in a bit. So after after those attempts to move those community proposals forward, and ultimately, since they didn't go back, in the fall of 2021, we were statutorily required to convene a statewide work group to come up with short, medium, and long-term strategies and solutions to tackling what was quickly becoming a crisis in the number of IST individuals being committed and ultimately referred to the department. This IST Solutions work group had representatives from all the various IST related stakeholders, so judges, PDs, DAs, county behavioral health, healthcare services, as well as advocates. We had family member participation as well. And that work group convened between August and November of 2021. And then the meetings and the information that resulted from those meetings ultimately culminated in a report that was submitted to the Department of Finance at the end of November of 2021. If you're interested in learning more and reading that report, I do have the link embedded on this slide here. And then we took the recommendations from that IST work group and developed a budget package for those strategies that were most viable to move forward between new treatment program investments and statutory changes. We are in the process of implementing about 20 of the 41 recommendations that were put forward by the work group. And in 2022-23, that's the first year of the authorized funding. We were authorized $535 million to implement the various strategies and solutions. And ultimately by 25-26, this increases to over $600 million. And just one other point here, that the IST Solutions budget package is, as I mentioned, it's a suite of strategies and solutions aimed at supporting the department's two primary goals. One is achieving compliance with that 28-day timeline by the Stiaveti Court. And then two, and more importantly, which is building out a community continuum of care to adequately serve our IST population. And this is just a depiction of the full and robust IST treatment continuum that we are working towards. Those blue boxes, if you can see the slide here, those blue boxes are more of our foundational programs. So state hospital beds, of course, as well as our conditional release program and jail-based competency treatment. And then all of the orange boxes reflect all of the brand new investments in either recent years, but predominantly through this IST Solutions budget package. Up at the top, we have some pre-admission programs. I'll just highlight the reevaluation services program, which is really going back into the jail settings and identifying and individuals who may have already restored a competency prior to admission into a treatment program, as well as our early access and stabilization services program. This is early engagement of treatment. As soon as we are made aware of an individual who has been committed to the department as IST, we will, where we have an early access program in the jail, we'll immediately begin providing treatment. The ultimate goal is to help stabilize that individual and then open up and increase opportunities to step them out of the jail and into a community-based restoration or diversion program. And then at the bottom there, it sort of rounds out our continuum. After state hospitals, we are now partnering with a number of private providers to increase the availability of community inpatient facilities. Again, another support to the stabilization of an individual if they need more time in that setting before they move into a diversion program. Forensic assertive community treatment. Those are typically more in residential settings, but the treatment services are delivered on site to the individuals, our CONREP program, and then community-based restoration and diversion on the least restrictive side of the continuum. So now moving into our just the basic framework for the Growth Cap program. Move into the next slide. These are our goals for the Felony IST Growth Cap program. Really three main points here. Main goal is to guard against the unintended consequences of the historical level of investments that have been made to fund in DSH funded community IST services. Also, we want to encourage efforts at the county level to reduce arrests and rearrests of individuals with serious mental illness and ultimately mitigate the continued growth in the creation of more IST individuals, not just those that are committed to DSH, not just to reduce those that are coming to our department, but overall reduce the number of individuals ultimately being arrested and committed as IST. And then lastly, to encourage participation in community IST programs such as diversion. Here's the basic framework. The program was established in Welfare and Institutions Code 4336 and was made effective in this fiscal year. It sets the baseline as fiscal year 21-22 for county's total annual felony IST determination count. This was the highest year on record for felony IST referrals to the department. Annually thereafter, a county would be charged a fee if IST determinations exceed the county's baseline level based on a tiered schedule. And then any funds collected from the counties are returned back to the county for reinvestment in upstream efforts to prevent arrest and rearrest of those with serious mental illness. So this slide depicts a breakdown of how potential fees would be assessed if and when a county's annual IST determination count exceeds the 21-22 baseline. So the way the statute is laid out during the first 4 years, no charge is assessed if a county exceeds the baseline by up to 4 IST determinations. Then tiered rates would apply for any additional IST would be applied for the 5th and 9th IST determination over the baseline. And then a county would be charged 100% of the fee or the rate for any additional IST determination at 10 or more in excess of the baseline. Beginning in year 5 and beyond, as the program has matured and more community IST programs are available, for counties not participating in IST community-based restoration or diversion, a fee of 150% of the charged rate would apply for the 3rd and subsequent IST determination over the baseline. And for counties that do have these programs, CBR or diversion program, the rate would remain at 100% of the value of the rate. A county can select any local funding source to make payment or apply any savings they may have from an existing DSH contract for IST services. And by statute, all fees collected, again, mentioning will be returned back to the county for reinvestment to support pre or post booking diversion, targeting individuals likely to be found IST, or reentry services of individuals who have been IST restored and maybe directly released back to the community, so we can prevent that cycle and that rearrest potentially from happening. And then counties must submit a plan for how funds would be utilized to receive their distribution, to receive the funds back to the county, as well as submit annual reports on the utilization of those funds. I do want to note that there currently is a work group that's established that's comprised of some county representatives that are assisting in the development of the plan. And so more information will be released as soon as that effort has been completed. So this is the initial timeline, the initial implementation timeline for the growth cap, just to level set on what's happened to date. Back in December of 2022, that's when we initially issued our letter to stakeholders regarding the program, how it works, associated timelines. And at that time, we did issue the baseline IST determinations for 21-22, as well as one quarter, the first quarter of fiscal year 22-23, unreconciled data for IST determinations. And then in February of 2023, we issued the second quarters of data. That is in both cases, that was our initial methodology that we had applied. We received a number of inquiries as to seeking clarity on the methodology at that time. And during the winter and early spring of 2023, we began engaging in communication with counties that were asking for more information. And then officially in May of 2023, we met with a coalition of county representatives and associations that represented key IST stakeholders to consider modifications to the program, all staying within the statutory guidelines. So now we'll go through our updates to the Growth Cap program. What has changed really centers around three primary areas. So we have updated the methodology by which we're identifying and counting IST determinations. This change has been applied to both the baseline, so the initial 21-22 baseline numbers, as well as all subsequent years, in this case, currently 22-23. We've also updated our rate, so rather than one rate that would be used to assess a potential penalty fee, we have established a tiered rate structure. And then also, based on a number of different requests for a dispute process, we've now implemented a dispute process. We've also implemented a process by which counties can designate an authorized representative to receive individualized detailed level data. So again, I just want to, and I'll probably plug this a few times in the coming slides, want to make a plug to, if your county does not have a designated representative on file, please let us know and see if we can get that established as soon as possible. Because once we have that individual on file with us, we will automatically send detailed IST data when it is available, both between our reconciled data as well as the unreconciled progress reports. So as years go on, you'll be able to reconcile and review the information as it comes forward. So just to kind of dive into the IST determination methodology, this slide is is showing what our original methodology was for both 21-22 baseline and then the unreconciled data for the first 2 quarters of 22-23. So at this time, really what captures the number of IST determinations are the referrals that are coming to the Department of State Hospitals or any one of our DSH funded programs. And at the time that we released the growth cap, this was based on what DSH was tracking as our initiation date. So when we received the referral and when it was entered into our system. And the reason really for that is because there sometimes can be a very significant lag as to when referral information is coming into the department, sometimes months on end before we actually receive that referral packet. And so in an effort to try to capture all of the information, we based it on an initiation date. And so referral information may have been applicable to other fiscal years in terms of their original commitment date, but yet because we did not receive that referral packet until another fiscal year, that is the year in which we applied that information to. I really highlight that because that's one of the primary changes that we've made in our methodology. In addition to capturing all of the IST referrals, we excluded any duplications, administrative errors, as well as individuals who may be transferred to multiple DSH programs. So we're not going to double count if someone has been initially admitted to a JBCT program and then may have to be transferred to a state hospital bed. Here's a summary of the updated methodology, again, trying to highlight that now, again, we're capturing all felony IST referrals that are committed to the Department of State Hospitals or a DSH funded program and are based on the commitment date of the IST individual. And really the date that the commitment order was made to the Department of State Hospitals or a DSH funded program within the respective fiscal year. In addition to those admin errors, duplications, transfers, we are also now excluding from the ultimate count any individuals who have passed away while they were waiting and prior to admission into a treatment program, any program individuals who may have been revoked from a program. So just to give you an example, if an IST individual was admitted into a, they were ultimately diverted initially and then are revoked from that program and they have to come into the Department of State Hospitals, we're not going to duplicate that count. We will exclude that second admission into the state hospital bed so that we're only counting for that one individual. And then any recommitments on the same charge. So, sometimes folks are found competent and then they are ultimately recommitted to us, but it's back on the same charge. Again, in an effort to avoid that duplication of that individual, we'll remove that recommitment. Any canceled commitments, sometimes a court may cancel the commitment. Think, a couple examples of this might be later down the line before admission into a DSH program, it's determined perhaps that DSH might not be the appropriate placement, that maybe the individual has a developmental disability and they are essentially redirected to another system, another type of program. When the court cancels that commitment and then reissues that order elsewhere, we're going to remove that individual from the count. Also, examples of the cancel commitments might be if someone has restored while they were waiting and prior to admission, a court may cancel that commitment ultimately as well. So those are all going to be removed from the total count. In addition, you know, most counties are participating, I think all counties are participating in the IST reevaluation program. These are this is a program that is in partnership with our sheriffs and jails across the state, where we have a panel of evaluators that are going in virtually to assess whether or not individuals on the IST wait list prior to admission to a treatment program may have restored a competency. And so for those that have been restored to competent, where we found they had already restored and we've deemed them competent, we wrote that report and sent that on to the court. We're going to remove that individual from the count of IST determinations. And then also, if you're a county that is participating in our early access stabilization services program, and we have an individual who is served by that program, they are ultimately restored before being admitted into a treatment program, a community-based treatment program, state hospital or JBCT program. Before admission to one of those, if they've restored, we're going to also remove that individual from the total count. In addition to all of the updates that we made on the base methodology, we are also implementing a credit related to diversion. It also applies to community-based restoration, again, because that is a form of diversion from jail. This diversion credit really it's a partial credit that will further reduce the county's adjusted total for IST determinations. The diversion credit will apply to counties who have placed an IST individual in community settings, either through a diversion or CBR program. And the reason why it's a partial credit is that it recognizes that both DSH and the county have a role in treating IST individuals in these programs, and that some individuals may ultimately be unsuccessful in their participation, which necessitates a transfer to a DSH facility, such as a state hospital bed, for continued treatment. Kind of the baseline assumptions here is that in terms of how we calculate the credit, the department's going to determine the statewide success rate for IST individuals admitted to a diversion or CBR program during the most recent prior 2 years. The current success rate that we're applying as of this year is 60%. And this success rate assumes the number of individuals who will successfully complete their program. The number that's derived by that calculation will then be reduced by half. And the reason for the additional offset is that it recognizes that we DSH typically initiate treatment for IST individuals to support stabilization, as well as that safe transition to a lower level of care in the community through diversion or CBR. And at the bottom of this slide here, you'll see a sample calculation to assist in visualizing how that credit would be applied. So now we'll just talk a little bit about the charged rates if a county's assessed a fee for excess IST determination numbers. Back in December of 2022, we published one rate. The methodology used to establish the base charged rate is based on our daily bed rate for treatment at a state hospital. And it also accounts for the average length of stay for IST patients that are served by the state hospitals. So for 22-23, the daily bed rate is $728 per day. and then we multiply that based on our average length of stay, which you can see here on this slide was 155 days. That average is based on the pre-COVID 3-year average rate. So between 2016 to 2016-17 through 2018-19. The reason why we applied that rate or that average length of stay is because it was lower than the average length of stay during the pandemic. So in total for 22-23, the base rate is equivalent to $113,000 annually per IST individual. Move into how we've updated things. We've now updated our fee, our charged rates to reflect a tiered rate structure that accounts for a county's participation in a DSH-funded IST treatment program. The Tier 1 base rate, as you can see here, is equivalent to the rate that we just talked about, $113,000 annually, reflecting the cost of IST treatment in a state hospital. And it's going to be applied to any county that does not operate any other felony IST treatment program bed. For counties that operate a JBCT, a CBR, or diversion program, the base rate would then be adjusted to reflect the statewide proportion of individuals that are admitted into one of these treatment programs. And in this case, the information is based on our experience in 21-22, and then also based on the cost of treatment in these particular programs. So again, utilizing the same daily bed rate, daily cost times average length of stay. And you can see at the bottom here of this slide, there's a breakdown of the assumptions that built the rates. Additionally, for any county that is operating an early access and stabilization service program in the jail, those tiered rates are further reduced by an additional 10%. So now I'd like to just touch on the individualized data that's available and designated representatives. The designated representatives, again, making a big plug, this is a very important component for counties to identify the individual or individuals, it could be multiple people, that can serve as a point of contact to the Department of State Hospitals who can receive the individualized data that we can make available for your review. And so our plan is we will continue to issue, as years go on, we will continue to issue on a quarterly basis unreconciled data applicable to each fiscal year. And when we issue those summary reports, if we've got a designated representative on file, we will automatically follow up those summary reports with the detailed data, and that will be sent to the designated representatives. So they will not only receive the information on a quarterly basis, but they will receive it at the main points in which we issue out our reconciled data for the year. And so again, this is just going to help each county track the changing status of the IST determination counts, right? And why that's also important is the individuals that are represented, say, in Q1, as these are folks that are in your count, their status could change, like in Q2, perhaps they have been reevaluated as competent and prior to admission to the treatment program. And so now that individual is actually now going to be removed from your count. And so that change is going to occur over time, and the numbers are also going to shift a bit. And then just also noting that the designated representative should be someone authorized to receive the data in accordance with HIPAA guidelines. And at the bottom here, you'll see this is on the slide, this is the individualized data that's available that will be provided essentially in an Excel type of spreadsheet report. The individualized data will include the name of the patient, their CII number, their gender, the committing county, as well as the commitment date that we have on record. We'll touch a little bit on the dispute process that we've now implemented. And again, this is in response to counties requesting the ability to dispute and reconcile potential discrepancies in the IST determination count. Again, making the plug, what's critical to this process is having that designated representative that we can work with. And essentially, you can just use the detailed report that we would be providing you as a designated representative. And you can essentially just identify which records on that report you may be disputing or you have some questions about. And we would ask that you provide an explanation, just outlining simply what the basis for the dispute is, and attach any supporting documentation you may have. It would be helpful to also attach that commitment order for the records that are being disputed. And then if for whatever reason the record is not represented on the document, you can also simply just fill out the information on the report and provide that supporting documentation so that we can follow up. And then also just to note that for 21-22 baseline data, we are currently in the dispute period for that process, which ends in November. Here's the dispute process timeline. Again, for this year only, we're offering 2 dispute windows, one for the 21-22 baseline calculation, and we will also have one for the 22-23 IST determinations once those are fully reconciled and reports are sent out to counties. For our baseline IST determination window, I apologize. It goes from August 2023 through October 2023. I will note that we do have a one-time, you have the ability to request an extension for an additional 30 days for that dispute period to end at the end of November. So essentially counties have about 90 days to submit their dispute. And then after we receive the information, we'll begin that reconciliation process. And then the bottom here talks about what the annual reconciled determinations dispute window will look like. We're working on the reconciliation of 22-23 data currently. That report's going to be released by the end of October. And then we'll have that 90-day window to submit the dispute for counties. DSH will then also have a 90-day window to review and respond. And then beginning in 24-25, we're going to reduce that time frame to a 60-day dispute window. And it's just a glimpse ahead. These are just a few key dates. This is not a comprehensive list. The comprehensive list is in the Growth Cap letter that's published online, or you may have received a copy via email. But just wanted to kind of highlight a few items. I've touched on this a bit. September 30th, this month, at the end of this month, is the deadline for the department to reconcile 22-23 IST determination data. You know, again, I'm going to make the plug that this is for the data that we have received, right, for 22-23. And so that's what's going to be reconciled by the end of this month. And then by the end of October, we will release the reconciled data report to the counties. So for sure, what's going to be published is the summary data, as you've seen in our departmental letters. And then for anyone that we've got, any county we've got a designated representative on file, the individual detailed data will be released as well. In November, again, after those reports are released, that the 22-23 IST determination dispute window opens. And then also to note, and I mentioned this earlier in the presentation, that we are in process working with some county representatives to develop a spending plan template. This is the document that is required for us to receive for distribution of the funds. We do envision that as is really kind of a one-time requirement unless your plan changes, and then you need to notify us of that. But really, I'm trying to keep that process simple. So there'll be more information in the coming months about that. And then we all are also working to develop some various training and technical assistance offerings to help with the planning process around upstream strategies to reduce IST commitments. Also provide some support around developing expenditure plans, as well as any of the annual reporting requirements that are laid out in the statute. I just want to plug this here. This is our collaborative community stakeholder work group grants. This is $100,000 annual funding that's available for every county. It's essentially just a direct allocation, and this is funding intended to assist with the planning of those upstream efforts. So if your county hasn't applied to receive this funding, you can find more information on our DSH diversion webpage, which is linked on the Department of State Hospitals homepage. If you can't find it, feel free to also just reach out to us and we'll get you connected to the right folks for that. That's it. I want to thank you, and then also identify a couple of references. If you have any questions, follow-up questions following this webinar, you can email the DSH IST Growth Cap email inbox, and most likely it'll probably be Julie that is helping us respond. And then also the Growth Cap letter and attachments can be found under our Growth Cap link on our webpage, where we have our departmental letters. And now again, we're going to share these slides out at the end of this webinar. So we'll email these out. We will also have them posted on our webpage for future reference as well. And so when you get a copy of these slides, the link will be live, so you'll be able to just click into that and it will take you to the right place to find the documents. We're also happy to email out the letter and attachments if that works better for you. If you were not part of the initial distribution group, you could just email us at that Growth Cap email inbox, and we'll forward you the letter and attachments as well. So with that, I know we only have a few minutes. I guess I ran through that almost an hour. There may be a number of questions, and so let's see what we can kind of get through at this point. And anything we can't answer, we will follow up as soon as possible.
And jumping right into it, Chris, I'm not sure if you want to take a couple of minutes just to show the web page. There's been a lot of questions in regards to where the policy is, or if the reports were released. We also had a question about where attachment D can be found. So I thought if you wouldn't mind sharing quickly just the link that is included in the slides, as you were saying, and we will send that out so people will be able to use that hyperlink to access them, but it might help for them to see it.
Sure. Yeah, I'm happy to do that. Just give me a second. I'm going to share my screen. And Julie, let me know if you can see this. This is our DSH webpage. So it's just www.dsh.ca.gov. And when you go to our webpage, you can see here we do have a link to the main letter, IST Growth Cap letter. But also where we have a lot of information is through this DSH diversion program link. And it'll, take you to this web page here talking about our various IST community programs. And there is a department letter section here. So I'm just going to kind of click on that. And we've got all of the various departmental letters that we've issued. Mostly it's related to diversion, but also you can find the collaborative community stakeholder work group funding. You can find that here, and how to apply. But this section here, I don't know if you can see my highlight here, but the growth cap letter, as well as all of the attachments. And I do have those posts pulled up, so just kind of run through those really quickly. You can see a copy of the letter here, which really runs through all of the background that we talked about today. This is a copy of one of the attachments. This is a copy of the baseline IST determination count. So this is the summary. And just to show you here, right, this first column here shows you, here's the total IST determinations, and then here's all of the counts that were removed from the total, what the update is, and then if a diversion credit has been applied. So that shows that information. We do the same for the 22-23 data. Now, mind you, this is unreconciled information because we're currently in the process of reconciling by September 30th, but wanted to issue this information. This was data that we had received through July 15th. So it's, it might be pretty close to complete, but wanted to get this information for your planning purposes. Also, there's an attachment that really walks through in much more detail the IST determination methodology, information about how to go about identifying your designated representative to receive individualized records, more detail on the dispute process specifically and the timelines, as well as more information on the penalty rate.
Thank you, Chris. And then just to follow up on another question, and this one's from Rick Bingham, who may need to elaborate just a little bit here so we can help you. The question was, how can we make a referral to or get access to the IST reevaluation team?
Oh, that's a great question. Rick, let me get back to you on that. Specifically, I'm sure we've got an email address, but we'll get you contacted. We do work directly with the jails and sheriffs across the state, and we're also evaluating the referrals that we receive. There is a process internally where we're also going out and being proactive about conducting the evaluations. But let me see if I can't get you that contact as soon as possible.
Thank you. And then we do have a question from Phoebe Bell in regards to using a rolling average or at least a one-time multi-year average for the baseline. It says especially small counties where there's a fluctuation of 1 to 2 people a year. It seems problematic that the baseline was a COVID year, is the comment.
Well, I thank you for that feedback. I mean, at this time, Phoebe, we had met with the coalition of different county representatives and had come forward with this methodology. At this time, we're not intending to update the methodology again. This is where we're at in the process, and I think a very good compromise in the sense that there are a number of adjustments that are being made to the total count of information.
Great. Thank you. And then another question, and I don't exactly know where we will be posting this webinar, but the question is, will we be posting it?
Yes, we'll be posting the webinar. Once we've wrapped this up, we'll I think email the link out, but then we'll also be made available on that DSH diversion webpage where you found the growth cap letters.
Great. We have about a minute left. I just want to scan quickly and make sure I didn't miss anyone. For the attendees, if you do think of questions after this, as Chris was saying, you can send them to DSHIST growthcap@dsh.ca.gov. We're happy to field those questions and get back to you later.
Thank you. I do see one here that says which department at the county is typically the representative on file? Is it behavioral health? Yeah, mostly it is. We do have, I think for the most part, behavioral health or health services representatives, county administrator offices. We may have a few of those folks as well. But the guidelines actually provide more detail about who can be qualified. And then there's also a process for you to just determine if you don't meet the categories, how else you might determine that you are eligible under HIPAA guidelines. Okay. Well, thank you so much. We'll work through all of these questions, and anything that we haven't responded to, we'll put together a little Q&A document and include that in our email distribution of this information. So thanks very much for your attendance, and see you all next time. Thank you.